Sir, we're waiting for two doctors more. Actually,
Okay, okay, okay.
then we'll start, sir.
Okay.
Subhasis? Subhasis, can you hear? Subhasis?
Hello. Yes, sir. Hello. Yes, sir. Mono, sir.
Yes, Subhasis, what is the update?
Actually, sir, I was in call with Dr. DN Mahapatra, sir, Alkala. He is facing some issue in joining. That is why taking down some time, sir.
Okay, and what about Dr. D.N. Mahapatra and Dr. Trinath
DN
Panda,
Mahapatra, sir, Trinath Panda, sir, just joining, sir. Actually, he has joined as a name Galaxy 22. So I guide him how to change the name.
Fine.
And DN Mahapatra, sir, is facing some issue, but he's joining soon, sir.
And this Dr. Sabir Ranjan Jana?
Sarah joined.
Okay, fine.
Devan Rao, sir, joined.
So then in that case, we can start, and
Okay.
the rest of the doctors will be joining meanwhile. Will it be okay?
Okay, sir. Okay, sir.
So should we start?
Yes, sir, we can start, sir. Biswaranjan sir is here, sir. Sir, should we start, sir?
Yeah, please start.
Okay, sir.
So, sir, let me introduce myself, sir. Sir, I am Manoj. I am a regional manager here, and this looking after this Bihar, Jharkhand, and Odisha area, sir. So, sir, first of all, sir, thank you to all of you, sir, for giving your consent for these scientific activities. And I would like to have this opportunity to welcome, sir, Dr. Biswaranjan Mishra, sir, who will be playing a role as a moderator in today's program, sir. And, sir, to talk about, sir, I'm no one to talk about, sir, but still, sir, sir does not require any introduction, but sir is based at Cuttack, sir, and he is practicing over as a DM cardio, and having a very rich experience in the field of cardiology, and has earned good name and fame also in entire Odisha market. So, sir, today we have other doctors also, sir, in the panel, and the doctors like Dr. Trinath Panda, who is from Talcher, and we have Dr. Sir Salendra Nayak, who is from Bhubaneswar, sir, and we have, sir, other doctor like Dr. Surya Narayan Gaura, sir is from Behrampur, and we have, sir, Dr. Uday Bhanu Raut, sir is from Bhubaneswar, and we have Dr. Samir Ranjan Zena, he is also, sir, from Bhubaneswar. We have Dr. Sir then S.R. Samal from Raulkela, and Dr. Badrikant Mishra from Cuttack, and then Dr. D.N. Mahapatra from Raulkela. So I welcome you all, sir, on this scientific forum. We call it as a MRA expert forum, in which we will be talking about, sir, the role of MRA in heart failure. And sir, Biswaranjan sir will be guiding us through his experiences and the scientific slides that is there, sir. So, sir, over to you, sir, Biswaranjan sir, and the session is yours, sir.
Yeah. Good evening. Thank you, Manoj. And I welcome and all the delegates. Very good evening to everybody.
Sir, sorry to interrupt you, sir. Just I request all the panelists to just switch on their video.
Okay.
It is important for our compliance team. So, sir, please keep your video on, sir. Sorry, sir. Sorry to interrupt, sir. Please
so this what I know it will be interactive session on heart failure, particular with emphasis on use of MRA. So you have a setup slide also. Should I share the screen, or we just keep on discussing?
Sir, it would be better if you can share the screen
Okay.
for the benefit of entire panel, sir.
Okay, is the screen visible now?
Yes, sir.
Yes, sir.
Your screen
Yes.
is visible, sir.
Visible. Yeah. So today topic is MRA, mineral receptor antagonist, a boon in heart failure management. As we know, okay, we have just agenda. We are going by the agenda. MRA's place in utilization of heart failure management. We'll discuss on that. Is hyperkalemia is a concern, and to create awareness among physicians on MRS. This is our objective today evening. Yeah. So heart failure is an epidemic portion in the globally. Prevalence is very high, and it increases with age, rising incidence of coronary artery disease, diabetes, hypertension. All these have increased the incidence of heart failure. And in India also the heart failure incidence is quite high. We know we are facing heart failure cases every day, and mortality is also quite high. And now the question is what percentage of heart failure patient approach you in stage 2, 3, 4, and how many heart failure patient goes undiagnosed in India at an early stage, and why? So if any panelist will participate in this, what percentage of patients with stage 2, 3, and 4 they see? Okay, you see the heart failure patients, unless they're symptomatic, they won't come to you. So what we see in the practice is usually stage 2 and 3, and stage 4 is a dyspnea at rest and they require hospitalization, and mostly they are hospitalized patients. So clinically, we generally see NYHA class 2 and 3 patient. Means class 2 means they are dyspneic on effort, unusual effort, and class 3 means they are symptomatic with ordinary efforts. Now, what are the diagnostic and prognostic tools used by you for heart failure patients? So, any panelist will answer or like to participate?
Sir, 2D को ECG.
See, diagnostic tools comes with patient symptoms.
The diagnostic tools is from clinical examinations and symptoms.
Right. So
basically pedal edema and dyspnea with raised JVP. Those are the classical symptoms. And to diagnostic, you can do 2D echo. Doppler study also you can do that.
Right. So from science, first thing is the patient may have some predisposing factor, like he might have old MI, he may be diabetic, is hypertensive, and we see symptoms are heart failure, like dyspnea is the most common, fatigue, pedal edema as you told, symptoms of right heart failure, and symptoms of left heart failure. Left heart failure is dyspnea, PND, orthopnea, and right heart failure is systemic congestion, edema, swelling, hepatomegaly, right hypochondriac pain. So signs are, classical signs, third heart sound, and hear a murmur, rails, red JVP as you told. So next steps, we have two options. One is we may go for a NT-proBNP, natriuretic peptide, or we may go for a diuretic and NT-proBNP. So these are the two diagnostic modalities, NT-proBNP, laboratory sign, and 2D echo. So 2D echo, we generally classify heart failure according to the ejection fraction. If the ejection fraction is less than 40, we straight away diagnose as a heart failure reduced ejection fraction. And it is relatively easy to diagnose by echo because you will see a poorly contracting left ventricle. But the other two are, if ejection fraction is 40 to 50%, 49% is a mildly reduced ejection fraction, previously known as heart failure mid-range ejection fraction. And if it is more than 50 and the patient has heart failure, we diagnose it as a case of heart failure preserved ejection fraction. So these are the categories, but reduced ejection fraction diagnosis is relatively easy by echocardiography and by symptoms, signs, chest X-ray, ECG. You know, a normal ECG doesn't rule out a heart failure, but remember, a completely normal ECG is very unlikely to have a heart failure. Some sinus tachycardia, left ventricular heart failure, left atrial enlargement, EPG, some abnormality is universally present. So abnormal ECG, chest X-ray, cardiomegaly, pulmonary venous hypertension. So it's easy to have a frank heart failure, reduced ejection fraction diagnosis easy. But in case of mildly reduced ejection fraction and preserved ejection fraction, the diagnosis by echo is a little challenging, but it's not that difficult. So these are the modalities, but remember to use optimally the NT-proBNP. All the BNP and NT-proBNP both are used, but we commonly use NT-proBNP in our practice. That is available also very commonly. So this their upper limits have been defined. In acute setting, the upper limit is higher, almost 3 times. If the patient is atrial fibrillation, the upper limit is 3 times. So that should be kept in mind. In some conditions like ACS, atrial fibrillation, and myocarditis, in the NT-proBNP may be raised. In some obesity, elderly age, NT-proBNP is also maybe falsely positive. So that should be in the mind.
Sir, one query, sir. Is it NT-proBNP is specific and selective to heart failure?
Yes. NT-proBNP is a marker of increased left ventricular filling pressure, stretch of atrium or left ventricle. So it is very specific, but sometimes false positive or little higher values of those we like 125 with the upper limit for NT-proBNP may get a little higher values in elderly people in pericarditis and myocarditis also. So that has to be clinically correlated, but it is a very specific marker for heart failure. In fact, in emergency, if the patient comes with dyspnea and you do NT-proBNP, it is normal, it rolls out a cardiogenic dyspnea. It may be acute exacerbation of COPD. So this has such importance role.
Okay, sir.
We'll move to next slide. There is 2021 update, 2021 European guideline, and we have a 2022 American guideline also. This has superseded the 2017 update of the ACC now. We have a guideline, full guideline from the American College of Cardiology. And caution should be exercised when MRA is used, because MRA increases potassium. The molecule itself, the mechanism is so that it increases potassium level. And in heart failure, we give the RAS blockers, ACE inhibitor, ARB or ARNI. Those also increase potassium. So combinedly, the potassium may increase. So it is increased potassium may be life-threatening. So this is one of the complications we should look for while prescribing medications. And renal impairment itself is a cause of hyperkalemia. So in renal impairment and hyperkalemia, you should use MRA cautiously. In fact, if it is more than 5 or there is the GFR is less than 30, you should not use MRAs. So any question?
Sir, one doubt, sir.
Yes.
If you start at what intervals we should check potassium levels?
Yeah, when you start MRA, ideally you should check potassium at 1 week. Then at 4, if it is normal, then at 4 weeks. if it is normal at 6 weeks. So that is the protocol. 1 week, 4 weeks, and 6 months. 6 months. 1 week, 4 weeks, and 6 months. If you are going normal, patient is stable. If it is abnormal and you are modifying dose, again the time starts from 0. When you have up-titrate or downgraded the MRA, you check at 1 week. If it becomes normal, then at 4 weeks, then follow up after 6 months. That is the interval. If the patient is stable, and you have to upgrade other drugs also, not only MRA, because there are four class of drugs in heart failure reduced ejection fraction you must use, like SGLT2 inhibitor, like a ARNI or ARB or ACE inhibitor, and a beta blocker also. So these 4 drugs should be optimized, and it is generally every 2 weeks you should look for ECG heart rate. You should look for urea creatinine, sodium, potassium, and you should look for symptoms and signs of congestion. Means is the patient of edema, dyspnea, these indicate congestion. When there is congestion, you should give diuretic. And now it is easy to diagnose congestion if you are working in ICUs also. You can use the ultrasound probe to see systemic congestion by the IVC dimension. It's very easy. If the IVC is dilated, the patient has systemic congestion. And you can put the ultrasound probe or echo probe, any probe over the lungs, chest wall. You can see the B lines. The B lines indicate fluid in the lung or pulmonary congestion. So these are easy way because we use stethoscope. It may not be very accurate and it requires high experience and clinical sense. But by ultrasound probe in a symptomatic patient, you can easily know if the patient is having congestion. If it's a congestion, you use a diuretic, and diuretic is gives symptomatic relief. Other 4 drugs like MRA, beta blocker, SGLT2 inhibitor, and RAS inhibitor. These 4 drugs are called disease modifying because they will reduce rate of hospitalization in future. They will reduce mortality. They increase life and quality of life also. So all these 4 drugs are to be used indefinitely and optimized. But if there is congestion, you should use diuretic to give symptomatic relief. So the general rule is you check every 2 weeks symptoms and laboratory parameters till the patient is stabilized, and you are upgrading drugs. And if it's not feasible in 2 months, practically it should be in a stable patient. It should be at 4 weeks every month till it's stabilized, and you are using optimal dose.
Thank you, sir.
So we'll go to the next slide.
Sir, one doubt, sir.
Yeah.
Sir, in patients of heart failure, usually CKD coexists. So yes. Can we use mineral receptor antagonist like spironolactone in patients of heart failure with CKD?
CKD, if the eGFR is less than 30, you should not use. If it is 30 to 49, means less than 50, between 30 to 50, you use half a dose. Like if you are starting a spironolactone 25, you should use 12.5. So it's a half of the dose. If it is more than 50, you don't have any restriction in CKD, but you should monitor the potassium level. But less than 30, you should not use mineral corticoids.
Sir, in CKD patient, how frequently you should monitor potassium? It is the same or different?
It is same. It is same. If the potassium is normal, then it is the same. You are checking at 1 week, so that is quite early also.
Thank you, sir.
So we have answered this 3rd question. Then recommendation. The recommendation of MRA for heart failure reduced ejection fraction is class 1. Class 1 means this is a strong recommendation. You should use. And for mildly reduced ejection fraction means if the ejection fraction is between 40 and 50 or 40 to 49, the recommendation is class 2B. Class 2B means it is moderately recommended. It is not very strongly recommended, but is moderately recommended. Means the trial results are in favor of these molecules. So it is 2B, but large randomized trials have not shown benefit. That is, so it is not like heart failure reduced ejection fraction. It is 2B in mildly reduced ejection fraction. Now the overview of management of heart failure reduced ejection fraction. Already I have told these 4 classes of drug, the disease modifying drugs. You should use a ARNI as a first preference, sacubitril valsartan combination, but the cost factor is there. So instead you can use a ACE inhibitor like ramipril, enalapril, or lisinopril. Or if the patient having cough, it's very cough is a common side effect of ACE inhibitor, so you can go for ARB like losartan or valsartan or candesartan, because these 3 ARBs have been used in trials. So telmisartan has not been used in heart failure trial. It is a very good effective drug in reducing hypertension before development of heart failure. But after the patient has developed reduced ejection fraction, the telmisartan use, the guideline don't recommend. It recommends losartan, candesartan, and valsartan because these drugs has been used in trials. The guidelines say those drugs which are used in trials you should use in the and the doses they have gone up to, you should try to go up to that drug, that dose. So these are about use of ACE inhibitor ARNI. Beta blocker, you should start with a low dose, carvedilol, bisoprolol, or metoprolol sustained release succinate. These are the 3 beta blockers recommended for heart failure. And mineral receptor antagonist as spironolactone and eplerenone, these are 2 recommended. You should start at 25 milligram, go up to 50 milligram also. And SGLT2 inhibitor, you know, the dapagliflozin and empagliflozin at 10 milligram are recommended for heart failure. And diuretic are recommended in all stages. I told if there is congestion. And there are advanced therapy, not very advanced therapy, but intervention related. So I said as implantable cardioverter defibrillator should be implanted because sudden cardiac death is a complication of heart failure reduced ejection fraction, particularly if the patient has ischemic cardiomyopathy. Ejection fraction is less than 30%, patient is symptomatic. If the patient is asymptomatic or class 1 with these drugs, you need not implant a drug or device. So ICD, implantable cardioverter defibrillator is an option, particularly in ischemic cardiomyopathy. And if the QRS complex is wide, because I am not able to read it properly. CRTS, the QRS complex is wide. That means the left ventricle is not contracting synchronously. So the contraction is not generating adequate cardiac output. So it should resynchronize the systole by putting electrode at different places in the coronary sinus, in the right ventricle, in the right atrium. So, you have to synchronize, that's called a CRT, cardiac resynchronization therapy. These are all intervention related. And we have second line drugs. Like if the heart rate remains high in spite of beta blocker, you go for ivabradine. You can use digoxin in symptomatic patient, but it's a class 2B recommendation. In ischemic cardiomyopathy, you see if there are viable myocardium, you go for a revascularization. So these are the other drugs. Isosorbide, dinitrated, hydrolyzine combination is used in African blacks. No, we don't have African blacks here in India. It's American recommendation. But in India, this combination is very commonly available, quite cheap also. We can use where you cannot use ACE inhibitor, ARB or ARNI because of hyperkalemia, or in patients of CKD, you can use this combination, isosorbide dinitrate and hydrolyzine combination. So any discussion regarding this medical management of heart failure reduced ejection fraction? There are 4 drugs, need not be started immediately, but if the patient is stable, you can start also. Now it is recommended that you optimize this start these 4 drugs before discharge of a patient. But we face many ambulatory patients who are in heart failure class 2, 3, and they are not hospitalized. And they are not going to be to come for follow-up very frequently, as is described in the guidelines. So you can, in stable patients, blood pressure is normal, you can just start with the initial doses, all these 4 drugs. or you may start with 3, one up like SGLT2 inhibitor, you can start in the next visit also. But you should look to use all these 4 drugs in heart failure, reduced ejection fraction.
Sir, in almost all the studies, they have used the dose up to 200, sir. So, in your personal experience, sir, have you gone with that 200 dose to any patient?
Hardly I am going beyond 100 milligram twice daily. So, in guidelines, they have used 100 milligram twice daily as an initial dose. But we always start with 50. If the blood pressure is higher, we start with 50 milligram twice daily and up titrate it. And most often we have to use 50 milligram half tablet twice daily. And many cardiologists do also use 50 milligram half tablets twice daily, then gradually up titrate, because hypotension is the most common side effect, unlike hyperkalemia. In my experience, I have seen hypotension more often than hyperkalemia, cough, or other side effects. So you have to measure blood pressure, or you can say the patient to monitor his blood pressure by a home blood pressure recording device. So you can up titrate or modify.
Thank you, sir.
What percentage of patient to MRAs in heart failure management? I think we should use in every patient, unless the CKD patient where there is a fear of hyperkalemia. Measure the potassium in spite of the CKD. It is not a very advanced CKD like grade 5 CKD, like 30 grade 4 5 CKD. You should use, but looking for the potassium. So every patient you should try to use. And when do you consider starting MRA in patient with heart failure, along with ACE inhibitor, ARB, and beta blocker? Although the combination of ACE inhibitor, ARB with MRA will increase the chance of hyperkalemia, but if an stable patient potassium is normal, you can use it together. So we use, the patient comes with the symptoms, like patient comes with congestion, we use a loop diuretic, tarsemide or furosemide, and it comes in the market with a combination. And to reduce the pill burden, we always write a plus combination of the tarsemide plus, like this, which combines with the spironolactone. And simultaneously, we also give ACE inhibitor, ARB. So it is a clinical practice to combine MRA with ACE inhibitor, ARB, and diuretic. So practically, we don't face much difficulty in the hyperkalemia. Very rarely we see hyperkalemia, and life-threatening hyperkalemia is also very rare. In fact, in the trial using ARNI and MRA, the clinically significant hyperkalemia is less than 1%. And beta blocker have a relation with potassium. You can use beta blocker with combination of MRA. And aldosterone escape in congestive heart failure. Aldosterone escape is a phenomenon, it's like it's a feedback loop. When you try to inhibit aldosterone, because RAS inhibitor, that ACE inhibitor, ARNI, ARB, all they are called RAS inhibitor. And RAS inhibitor also inhibit aldosterone, because RAS means renin, angiotensin, aldosterone axis. So they are also aldosterone inhibitors. So because of the feedback loops, there's a escape, the aldosterone level increases. So in those cases, it is better to combine with MRA so that the escape doesn't occur. And if it occurs, it takes care of it. That's what this slide means, I think. And comparing aldosterone with eplerenone, spironolactone with eplerenone, there's some trials with combining, like the FSS trial, and there are 2 trials with eplerenone, FSS and emphasis heart failure trial. With spironolactone, that's RAILS trial. So there is some in view in terms of improvement ejection fraction. There are some report of eplerenone improving the ejection fraction more than spironolactone, but the data of the results are not so robust that you should use eplerenone instead of spironolactone to improve EF. When do you prefer using eplerenone, spironolactone, any specific patient profile? Eplerenone is more selective. So the gynecomastia or the mastalgia, vaginal bleeding, they're less common. So, but eplerenone is quite costly compared to spironolactone. So when a patient can afford, you can go for eplerenone. First choice is eplerenone because to reduce the side effects. Those adjustment I have told already. If the EEHF are more than 50, that full dose you can give. Potassium is less. If it is high, you have to less than 5, you don't require any adjustment. 5 to 6, you have the dose, and more than 6, you should not use because it may cause a life-threatening hyperkalemia. And what is the preferred dose? How is the dose titration carried out in your practice? That I have already told you. Start with 25 milligram, both spironolactone or eplerenone. Start with 25 milligram. Then in subsequent visits, usually in 2 weeks for all other drugs, if the patient's potassium and creatinine are normal, you should go to 50 milligram, and that is the you should maintain with 50 milligram. The upper dose limit is also 50 milligram, but heart failure reduced ejection fraction or mildly reduced ejection fraction. So you should continuously use 50 milligram and monitor the patient. The hyperkalemia, the trials have shown it is not a very significant side effect in some patients. As I told, it's the clinically significant hyperkalemia occurs in less than 1%. So this is not a very concern for clinical use. So now, in what percent of heart failure patients MRA develops hyperkalemia? I told less than 1%. And how these patients are managed. So the management of hyperkalemia due to MRA or due to hernia or ACE inhibitor. Management is to discontinue drug, wait, see the rebel, start with lower dose. That is the first strategy of management. And the second strategy is you use a potassium binder and continue the drug. So potassium binder you can use regularly. So some drugs have been approved by the FDA, like patiromar, sodium zirconium, polysalicylate. Like these two drugs are, but the recommendation is weaker for to combine a potassium binder and go for this. In future trials, maybe that will be recommended in if the patient is hyperkalemia with MRA, because MRA and RNA should be used to modify the disease. If hyperkalemia occurs, the drugs are stopped and the purpose is defeated. So you use a potassium binder, decrease the potassium level, and use RNA and MRA. That is the newer concept, and people are doing research on this. And 2 drugs have been approved, but not the recommended is not class 1. Now the recommendation is 2B, weaker recommendations, because some trials have shown benefit of this strategy. Now the timing of eplerenone initiation and outcomes in patient with heart failure. You start with all stable patients, and even the patient is hospitalized, you are giving IV diuretic, you can give oral eplerenone also simultaneously in class 4 patients also. So LV systolic dysfunction, because earlier trials, eplerenone, it was so the post-MI patient, they benefit maximum when there is systolic dysfunction. But now the concept is any cause of systolic dysfunction, any heart failure reduced ejection infection due to any cause, whatever the cause, not only coronary artery disease, the eplerenone has benefit. So every heart failure reduced ejection fraction, it should be used, not only post-MI. In clinical practice, how early MR is initiated, I already told in you should use in class 4 patients also. Any discussion or any question? This slide I have discussed already. The first 4 drugs and diuretic, the 5 drugs are class 1. Disease modifying drugs are ACE inhibitor, ARB, RNA, beta blocker, MRA, DAPA or MPA, and diuretic for symptomatic relief. And ICD and CRT I have discussed already. Now, what is the preferred choice of therapy? All of you are using this combination: torsemide, eplerenone, torsemide, spironolactone. So you can say what you prefer. Yeah. I think this preference depends. Eplerenone and torsemide is a good combination. This should be preferred, and naturally the cost is higher when there is eplerenone, so we should consider it. But eplerenone and torsemide as a loop diuretic and eplerenone as a MRA, this combination should be preferred. So in your practice, any other indication apart from heart failure? Can anybody, the others are using it in any other indication? Manoj, Samir. Manoj, you are muted.
Sir, I would request other panel member to please participate and give your valuable thought on this.
Right, yeah.
Apart from the heart failure, we are also using it in any kind of ascites, maybe cirrhosis liver. In those cases, anemia with hyperproteinemia, having edema. In those cases, also we are using.
Yeah. Because this is a diuretic, potassium sparing diuretic. So when you are using a loop diuretic, it has the effect of reducing sodium and potassium, particularly hypokalemia. So you should combine with a potassium sparing diuretic, whatever the cause of edema, like cirrhosis of liver, anemia, whatever. There is a fluid accumulation, constitutive pericarditis also. You use it with a combination with loop diuretic. But the most important other use of this aldosterone MRA is in a resistant hypertension. So you are using 3 drugs, including a thiazide diuretic. The BP is not controlled. You have titrated calcium channel blocker. You have titrated ARB. You use a third is a thiazide diuretic, but BP is not controlled. So you in resistant hypertension, what I meant to say is in resistant hypertension is an indication of use of MRA, and BP will be controlled, mind if you use MRA in resistant hypertension.
Yes, sir, we use that also.
Yeah. That is.
Sir, in your previous slide, you have said dapagliflozin is also used, but dapagliflozin in as a diuretic.
Not a diuretic. It has a diuretic effect. DAPA is basically used. It is a
that is SGLT. That is SGLT2. Yes, yeah. But is that used in the heart failure without diabetic cases?
Yes, yes. It is one of the drugs recommended for heart failure reduced ejection fraction, whether there is diabetes or not. So if the patient is non-diabetic but comes with a dilated cardiomyopathy, ejection fraction 30%, patient have a congestive heart failure, it is mandatory you should do SGLT2 inhibitor, whether the patient has diabetes or not.
With the same dose, sir? 10 milligram
yes,
or
10 milligram. 10 milligram starting dose, 10 milligram is the maximum dose, because that is the dose which is tried in the trials.
Okay, sir. Okay.
So if there is diabetes, and a cardiovascular disease, heart failure or not, suppose the patient has a diabetes.
In that case,
yes.
No, without diabetes, that is what I am.
Yeah. Without diabetes, now it is a class 1 indication for DAPA and also MPA. Even in heart failure preserved ejection fraction, it is SGLT2 inhibitor indication is upgraded from 2B to 2A, means there is a moderate recommendation even in heart failure preserve ejection fraction. So
Okay, sir.
SGLT2 inhibitor now is recommended in heart failure without diabetes also.
Okay, sir. Thank you.
I think it's the last slide. What scientific initiative would you suggest?
Yes, sir. You all are invited to give your valuable suggestions that obviously in scientific initiative, what we should change, I mean, how we should change or what we should add. So your valuable suggestions are welcome, sir.
First
You
thing
have already
is
both the products you have, I think.
yeah.
Both the
Yes.
combination you have.
Yes,
I
sir.
think
We have, sir, both the
with
sir.
diuretic with spironolactone with and also with the epinephrine, both you have.
Yes, sir. We both have, sir.
So what more you can suggest in MRA at least?
No, we are, sir, coming with our own Ernie brand also, sir. Because it is going to be off patent in this financial year.
So in that case, you should reduce some price. At least it should be affordable.
Obviously, sir, it is going to be off patent, so price will be reduced already, sir.
There will be competition, a lot of competition,
Yes,
and price will reduce.
A lot more companies are supposed to come, sir. By the end of 2022, I think there would be n number of companies who will be coming with this Ernie brands.
Okay.
So thank you, sir. Thank you. If there is anyone who would like to give some suggestions or some enlightenment on this topic, sir, you are welcome. Otherwise, we would include the session, sir.
I will suggest that the diagnostic, unless you diagnose, you cannot treat. So the physician should be aware of diagnosis and use this NT-proBNP more often in dyspneic patients, because that is available, is not a very costly one. So NT-proBNP use should be more widely done. That is my suggestion to the physicians.
Yes, sir.
So, sir, would like to have your suggestions, sir. If you are having no queries, sir, we should conclude the sessions because your time is obviously very much valuable, sir.
Yeah, you can conclude.
Okay, fine, sir. So, sir, I would like to thank each one of you, sir, for giving your valuable time, for your active participations, and hope the discussion would have been fruitful for your day-to-day practice, and sir would have been able to solve your queries, whatsoever the queries you are having regarding the use of MRA in heart failure. And sir, so thank you, sir, Biswaranjan sir, also for giving your valuable consent and time, sir. And in next future also, sir, we will be gathering together, sir, on this scientific program. So thank you, everyone, sir. Good night, sir. Have a nice time, sir.
Good night.
Good night.
Thank you.